Good morning, everyone, and welcome to today's webinar, the Fertility Workup, presented by Dr. Ann Korkidakis. Before we get started, I would like to go over a few quick items about today's event. First, all physicians in attendance today will receive an AMA PRA Category 1 credit, and all of the other providers will receive a certificate of completion for 1 contact hour credit. The certificate will be emailed to you by Harvard around mid-summer. Dr. Korkidakis practices at our Worcester, Waltham, and Springfield locations, as well as by telemedicine in Massachusetts. She graduated with honors from McGill University, then went on to complete her medical degree at McGill University, followed by a 5-year residency in obstetrics and gynecology at Queen's University. She received training in reproductive endocrinology and infertility from the University of British Columbia and holds a master's in public health from Johns Hopkins University. She then completed her 3-year fellowship with Boston IVF, Beth Israel, and Harvard. Dr. Korkidakis is fluent in French and Greek and English. We encourage you to submit questions to Dr. Ann Korkidakis using the questions section of the control panel. You may send in your questions at any time during the presentation. We will collect these and address them during the questions and answer session at the end of today's presentation. All right, we're going to get started. I'm going to pass it over to Dr. Korkidakis.
Good afternoon, everyone. I'm really excited that you're all joining me today for my talk going over the fertility workup. And please send in your questions at the end. I would love to hear from you all. So in terms of objectives, we'll start with trying to be able to identify when to initiate testing for infertility based on patient characteristics. Select the appropriate fertility testing modalities for your patient, and then know how to interpret these findings in order to allow for treatment initiation and consultation. So despite many young women spending their younger reproductive lives trying not to conceive, the chance of live birth per month in humans is actually quite low. So that's the term for it is fecundability, the chance of live birth per menstrual cycle. This is for heterosexual couples just starting to try to conceive. The chance in your 20s and early 30s is roughly about 15 to 25% per month. And you can see that the curve starts sloping down starting at about your mid-30s, and then the decline steeper in the late 30s and early 40s. The dotted line here represents the miscarriage rate, and you can see that the baseline risk of miscarriage is approximately 5 to 10% per month, but that also does rise starting your late 30s and early 40s. So when you put this all together, roughly 75% of heterosexual couples will get pregnant in the first 6 months of trying to conceive. That means the vast majority of them will be pregnant within that 6-month time frame. 85% by 1 year. So you can see that there's an additional 10% that will be successful in the subsequent 6 months. And then after that, it's about 90% per 2 years. Now, this is in contrast to the swamp wallaby, who is known to be one of the most fertile species on the planet. They actually have essentially a uterus didelphys. So 2 cervices, 2 uteri, each with a fallopian tube and an ovary. And what's interesting is even prior to delivery, there's a new conception that's implanted in the other uterus. So they spent essentially their entire female reproductive lives being pregnant. Doesn't sound great. So in terms of an infertility diagnosis, generally it's defined as not being able to conceive after 1 year or longer of unprotected intercourse. And we'll speak to this a little later, but it's reasonable to consider evaluating and treating in women over 35 after 6 months of trying to conceive. And then immediate evaluation can definitely be considered if a woman's over 40 and trying to conceive for the first time. The reason why is you saw that steep slope in your late 30s and early 40s. And essentially, it's not unreasonable to make sure that the couple's well set up so that the fallopian tubes are open, that she's ovulating regularly, and that the sperm is within normal ranges to at least give them a good shot at success. Now, these are very common patient misconceptions when it comes to being diagnosed with infertility. There's a lot of focus on monitoring ovulation, and we'll kind of go over how we can counsel patients on that. But a infertility diagnosis does not require tracking ovulation. It also doesn't require having intercourse every 1 to 2 days throughout the entire month. Essentially, they're having intercourse, a couple times during their ovulatory week. Over a 12-month span, they meet the diagnosis of infertility. The other thing that is commonly misunderstood is that this can be diagnosed even if the couple has a history of a miscarriage, ectopic, or biochemical pregnancy during that period. So the couple's been trying for 12 months, but they did have a biochemical several months ago. That doesn't take away from their infertility diagnosis, meaning that the pickup rates for testing are definitely higher in that patient population, even if they've experienced those adverse events. Now, we're all very familiar with the fact that female reproductive age is very closely intertwined with fertility. And there's a few reasons for that. And they're all related to essentially the eggs. We can see that the live birth per embryo transfer using own eggs is roughly about 40 to 50% in late 20s, early 30s, but that also declines, just like the fecundability chart we've seen. And in fact, ART does not completely reverse the effects of aging. So we can see that for a 42-year-old, the chance of success per embryo transfer, meaning they've had to get to that point, is less than 10% per transfer. And our cutoff here at Boston IVF for autologous IVF cycles, meaning IVF cycles using a patient's own eggs, is approximately 44 years old, because at that point, the chance of conception using ART is less than 5%. And other options can be considered. I think this chart clearly emphasizes that this is all related to the egg, because when we do use donor eggs, the success remains very, very high, even in their late 40s. Our cutoff for using donor eggs for female age is approximately 50 years old, and that's just due to the increased risks of pregnancy at that age range. So there's two characteristics to eggs. The first one we'll talk about is the quantity of eggs, how many eggs a woman has at a given point. Women are born with all the eggs we'll ever have, whereas men are continuously making sperm. Not a really fair setup, but it is what it is. Women have the most eggs they'll ever have when they're actually in utero at approximately 20 weeks gestation. They have 7 million eggs at that point. By birth, this goes down to about 1 to 2 million. At puberty, once they start having menstrual cycles, it's about 500,000. And then at menopause, we say no eggs left, but essentially the number truly is less than 1,000 eggs. Now, how are these lost? In the background, women are making a cohort of eggs. If they have ovulatory cycles, then this cohort is moving forward through the gonadotropin-dependent phase, meaning it starts to be responding to FSH. One dominant follicle has higher concentration of FSH receptors and takes lead and ends up ovulating, and the rest undergo atresia. And that's how you go through so many millions of eggs up until the average age of menopause, which is approximately 51 years old. Another common misconception is that women who aren't having regular cycles because they're on continuous oral contraceptive pills, or they have polycystic ovarian syndrome or hypothalamic amenorrhea, aren't losing eggs. But in fact, they are. There's this gonadotropin independent cycle when the eggs are quite small in the early phases that's under paracrine control. So this loss is happening in the background, even in women without regular menstrual cycles. Now, we spoke about quantity. The next characteristic of eggs is the quality. Now, just as a quick refresher, oocytes are arrested at prophase 1 and meiosis 1 up until the point of ovulation. So they complete the stage. Let's say if a woman's ovulating egg at 20 versus 40 years old, that's an extra 20 years that an oocyte's arrested at the stage. It then completes meiosis 1 after ovulation, and then becomes arrested in metaphase 2 of meiosis 1 prior to fertilization. Now, why is this important? This is important because there is a spindle apparatus, as we all know, that brings these chromosomes and drives them apart to separate first the homologous chromosomes and then the sister chromatids. And the spindle apparatus is made of protein and can degrade over time. So there is a difference when a woman ovulates an egg at 20 versus 40, and at that point are completing meiosis 1 and meiosis 2. Because if there's a breakdown in the spindle apparatus, there could be an unequal distribution of chromosomes. So there can be eggs with extra chromosomes, such as trisomy 21, which we all know leads to Down syndrome, but there can be missing or extra other chromosomes that lead to issues with miscarriage or infertility, and that risk does increase with age. So this chart depicts the proportion of embryos which are aneuploid based on maternal age. So this is based on over 100,000 biopsies of embryos using the pre-implantation genetic screening for aneuploidy or PGTA technique. You can see that in your 20s and early 30s, there's definitely still a chance of embryos being aneuploid or abnormal, having the wrong number of chromosomes, not being 46XX or 46XY. That risk is approximately 25 to 30% in younger years. Now, these are stats, so it's not an absolute truth in terms of, if a couple has 4 embryos to biopsy in this age range, sometimes there's only, 1 that's abnormal, and sometimes it's all 4. But on a population level, this is what it looks like. And you can see the rate of abnormal embryos does increase over time to the point at 43 or 44 years old, the chance of aneuploid is almost 90%. Now, you can understand that a lot of steps go into, even getting embryos to being able to be at the stage where they can be biopsied. So there's a lot of women in their 40s that don't even get to the stage of biopsy. But if they are at that stage, they still face this issue of high rates of fetal aneuploidy or embryonic aneuploidy. Again, this speaks to why we have a cutoff using autologous eggs. Now, what about men? This is a question my patients commonly ask, and I think that it's good to kind of share the blame in a way. The issue with men and reproductive aging is that there's no universal definition of advanced reproductive age. Studies have used various age thresholds. You can see the fertility rate does go down, particularly after 45 years old, but it never approaches 0 to the same way that it does for women in their mid to late 40s. Other changes that we see with advancing male reproductive age is decreasing testosterone levels. That's the most marked endocrine change, and this can lead to poor libido, fatigue, sexual dysfunction. There's also lower semen volume and sperm motility with advancing age. And then there's increased risks from a fetal perspective. So there are studies showing that men over 45 to 50 years old are more likely to have offspring diagnosed with autism, schizophrenia, and then certain autosomal dominant conditions such as achondroplasia and Alport syndrome. So when do we evaluate? At least 12 months of unprotected intercourse if a woman is under 35 years old. After 35, then that number gets moved down to 6 months. After 6 months of unprotected intercourse, it's worth evaluating. Again, it's not inappropriate to consider immediate evaluation if a woman's over 40 years old, just to kind of ensure that they're set up for success. And then what's often missed is that sometimes it's appropriate just to refer a patient right away. If the patient has irregular cycles and is menstruating every 60 to 90 days, they're likely not releasing an egg. They're not ovulatory. So their chance of conception on their own is incredibly low. So essentially, it can sometimes be just a waste of time to kind of let them go that 6 to 12 month period. So it definitely makes sense to initiate some testing to try to sort out why they're not having regular cycles right away. If they have risk factors for tubal disease, such as recurrent pelvic inflammatory disease or multiple pelvic surgeries, if there's suspicion for male infertility, if there's a history of cryptorchidism, if there's sexual dysfunction, so it's not uncommon over time, over many months of trying to conceive, sexual dysfunction becomes more pronounced and can be a limiting factor. recurrent pregnancy loss, which now the revised definition is 2 miscarriages. They do not have to be consecutive. At that point, it makes sense to start evaluating for recurrent pregnancy loss because the pickup rates are higher than the baseline population. Also important to note that biochemical pregnancies fit within this definition. So 2 biochemical pregnancies does warrant further testing. We also see a lot of same-sex couples looking to build a family, individuals looking to become single parents by choice, individuals about to undergo gonadotoxic treatment, whether chemotherapy or starting testosterone therapy for gender affirmation. And then many individuals interested in elective fertility preservation, which is a very proactive approach. In terms of the etiology for infertility, it's surprising that 40% of couples actually have combined factors. And this is why when we do the workup, we tend to do a comprehensive evaluation. Even if the patient has irregular cycles and we think this is a main contributor, it doesn't mean that there can't be a concomitant male factor in these situations. So the ASRM released 2 years ago a guideline on a female fertility evaluation. And I really enjoy it because there is a chart going over even kind of points on history that oftentimes are overlooked. A few things I'll bring up. As I mentioned, presence of sexual dysfunction. There's definitely a correlation with couples trying to conceive over time and having increased rates of sexual dysfunction. Again, that can limit the frequency of intercourse they have. Then oftentimes couples have had either individually with other partners or together long periods of unprotected intercourse that they don't consider to be periods of trying to conceive. So I like to specifically ask on history, has there ever been a point of time with your current partner or prior partner where there were repeat acts of unprotected intercourse over a time span? And again, this addresses this consideration. And that's important because the length of infertility does correlate with outcomes. So certainly if someone's had, a 6-year period of unprotected intercourse, and then over the last 6 months have been trying to time things, and they themselves label this as their period of trying to conceive, their prognosis is worse than a couple that have only been trying for 6 months. And we'll address this at the end, but fertility tracking, and especially in women with irregular cycles, does have significant limitations, and there sometimes can be an over-reliance on these modalities. So in terms of gynecologic history, I like emphasizing whether or not there was a history of any significant dysmenorrhea. I think overall, that there's a misconception that periods are supposed to be awful and painful and difficult to deal with. And I think that a lot of times we're missing pathology there. So I specifically ask, do you have to take anti-inflammatory medication regularly? Do you ever have missed school or missed work due to pain around your periods? And if they do, I'll dig a little deeper and ask about a history of dyspareunia, pain with voiding, just to try to get understanding of whether or not they have a risk of having underlying endometriosis. And we'll get to that here. And it is an important aspect because up to 50% of women with infertility do have endometriosis. And kind of the reverse is true, that women with endometriosis are 2 times more likely to experience infertility. And it certainly is multifactorial. First, if they're having pain, again, that will limit sexual acts and can cause issues with conception. The other aspect is it can reduce the ovarian reserve as well as egg quality. Certainly scarring over time from the endometriosis itself or from repeat surgeries can lead to tubal factor and gamete transport. The inflammation is thought to impact some of the receptors in the endometrial lining, and there is an association between endometriosis and impaired embryo implantation. So certainly multifactorial and an ongoing area of research. This is important because women with advanced endometriosis are much more likely to need more advanced technology, ART, to be able to successfully conceive. So this is something that always gets flagged on our side. Other aspects of gynecology, gynecologic history, sometimes when you kind of delve deeper, some individuals have actually never had menstrual cycles spontaneously. So they had experienced primary amenorrhea up until 15, 16 years old, and someone put them on the OCP and they've been on it ever since. And so that's very important. I think there's a lot of undiagnosed common syndromes out there and other reasons for primary amenorrhea. The other aspect is if the patient does not have regular menstrual cycles, meaning if they're less than every 21 days or greater than 35-day intervals, then this really should be a big red flag in terms of evaluating for other potential etiologies. Specifically ask about thyroid symptoms, hirsutism, visual field defects trying to get at a pituitary lesion, galacturia for possible prolactinoma, stressors that might lead to hypothalamic amenorrhea, that could be both physical as well as psychologic, dietary and exercise habits, severe caloric restriction, excess exercise. This all leads to a negative energy balance and can be a risk factor for hypothalamic amenorrhea, and then vasomotor symptoms as a flag for potential premature menopause. So this is a big point in my history taking. The patient presents for infertility. It can essentially take 3 different paths just from the menstrual cycle. So they're having regular cycles, meaning every 21 to 35 days, even if it's kind of varying within that interval. They're having cycles roughly once a month. Then you're pretty safe to say that most of their cycles are likely ovulatory. There's really no mechanism for a woman to have regular menstrual cycles without them releasing an egg, and we'll go through that in a little bit. So then I start looking for other causes, and I don't have to test for ovulatory disorders or confirm ovulation. Whereas if a patient says that they're having cycles every 60 to 90 days or even less frequent, then there's no clinical evidence of ovulation. And then you have to investigate further as to why they have irregular cycles. So that's when you would check TSH, prolactin. Prolactins are hormone only order if they have galacturia or irregular menstrual cycles, FSH, LH, and then ruling out PCOS. Now, if the menstrual cycle is that it's uncertain whether or not they ovulate, they have maybe every 40-day cycles, or they're not taking great menstrual histories, then at that point, it definitely is reasonable to do a cycle day 21 progesterone to see if the progesterone's over 3. If it's over 3, essentially that confirms ovulation. Now, there's a lot of questions on what progesterone level suggests is sufficient luteal support. And the answer is that we don't have a way to diagnose luteal phase deficiency. Progesterone is cyclical, and this is a graph looking at one individual's serum progesterone levels over a 24-hour period. Some thresholds of 10 have been used to try to diagnose luteal phase deficiency, but you can see that a normal fertile woman sometimes dips to levels less than 10 during luteal phase in a normal cycle. So again, we don't really care about the absolute value as long as it's over 3. That confirms ovulation. In terms of diagnosing PCOS, there's a few different criteria. We tend to favor the Rotterdam criteria, and you have to have 2 of the 3 findings. So clinical or biochemical hyperandrogenism. So I tend to order some of the irregular cycles if they do not have signs of clinical hyperandrogenism. I do tend to add either a total or free testosterone to see if there's evidence of biochemical hyperandrogenism. Irregular cycles, and then polycystic appearing ovaries and ultrasound. And again, it's important that the diagnosis can only be made after exclusion of other etiologies. So there's a diagnosis of exclusion. So you have to make sure that there's no thyroid disorder, there's no congenital adrenal hyperplasia. All that has to be ruled out before they're given this diagnosis. In this patient population, it's also important to flag any signs of virilization. So the symptoms and signs that I find most concerning are clitoromegaly, a deepening of the voice, loss of breast tissue, or temporal hair recession and balding. Those to me flag that really we should be measuring androgens to make sure that we're not missing an androgen-producing tumor. In terms of the length of the menstrual cycles, there's definitely more irregularities in the extremes of the reproductive age. So in the earlier cycles, there's a lot of anovulatory cycles until the normal axis kicks in. And then in your mid to late 40s, it's certainly normal for the cycle interval to increase. It tends to decrease before it increases. And the reason for that is luteal phase is fairly constant, but there is a faster follicular phase. And that's because as the ovarian pool declines, there is less of inhibin, which it means that there's less of feedback on FSH. So older women or women with reduced ovarian reserve do see higher FSH levels. And this higher FSH level is what makes follicles develop. So the higher the level makes this follicular cohort develop faster. So the reason that why women prior to menopause first experience shorter prior to longer cycles is that the higher FSH leads to a shorter follicular phase. And so that's always a flag to me on history. If a patient says my cycles were always 28 days, but then last year they've been every 24. To me, that's concerning. And I'm really looking for that FSH level to see if there is a sign of a decreased ovarian reserve kind of influencing that elevated FSH, shortening the cycles. Just to quickly go over the menstrual cycle, this is a bit redundant, but I think it's always good to rehash some of these steps. So as I said, there's a cohort of follicles that develop every month. This is precipitated by follicle stimulating hormone. One of these follicles, because of a higher concentration of FSH receptors, takes the lead. Healthy follicles produce estrogen. This estrogen at low to moderate levels is an inhibitory on the FSH and LH. But then at higher levels, it tends to have a positive feedback mechanism. So at higher levels, it induces a LH surge, which triggers ovulation. And once the egg is released, the remaining cyst, the corpus luteum, secretes progesterone. And that's why essentially a progesterone over 3 confirms ovulation. It's really the only point in the menstrual cycle we would expect an elevated progesterone. So going back to history, a lot of this is taken better by you than even by me, but going through an obstetrical history, flagging any complications, any need for optimizing health preconception. Similar medical history is important to kind of flag any issues that need to be taken care of prior to pregnancy, as well as any potential contributors to infertility. In terms of family history, the factors that sometimes are flagged on my side is a history of developmental delay or early menopause. To me, that prompts me to ask about a potential for Fragile X. And Fragile X is tested in our carrier screening. So it's something we look out for, particularly if they have this on family history. And then multiple spontaneous abortions. It's not uncommon for some patients to say, yeah, my mom experienced several miscarriages and her mom did as well. And to me, that's a big flag to do a karyotype to ascertain whether or not they carry a balanced translocation, meaning they carry all the appropriate chromosomal content, but some of them are rearranged. So when the gametes divide, they're more at likely risk to divide unequally. Social history, again, is important for health optimization. And then in male history, another thing that's been coming up more and more is exogenous steroid use. Again, infertility is associated with sexual dysfunction, can cause lower libido, and there is some patients that go off and start testosterone to try to target and improve these symptoms. But it's important to counsel them that testosterone actually acts as a contraceptive. It reduces gonadotropin levels and decreases both testosterone, endogenous testosterone production, as well as sperm production. So to me, this is really important, a really important element on history. So when it comes to testing, this is a chart I like to show patients just to kind of go over the basics. Essentially, this is all we need to achieve a healthy baby. First, we have to make sure that the mother's health is optimized prior to pregnancy. So we order some carrier testing, rubella, varicella titers, an infectious disease screen, a TSH. That's just to make sure that the health is optimized from a prenatal perspective. If the woman's having regular menstrual cycles, I am not doing ovulation testing, but if they're irregular, then that's something you can confirm. Having an idea of ovarian reserve is important because it defines a reproductive window and chance of response to treatment, and we'll talk a little bit more about that. But for us, that means a cycle day 2 to 4 FSH, an AMH, and an antral follicle count on pelvic ultrasound. I will say that a lot of outside ultrasound companies do not perform an antral follicle count, but for me, it's important because it helps validate what I'm seeing on serology. So we know that we're confirming that we have eggs and a good reserve. We know that the patient's ovulating, she has regular cycles. Next step is to look at the tract. We need to make sure the uterus is normal with no polyps or fibroids in the cavity that could impact implantation. And then we have to ensure that the fallopian tubes are open. We tend to order hysterosalpingograms for this, which consists of putting a little contrast through the cervix to open up the uterine cavity and then fill the fallopian tubes, let it extravasate into the abdominal cavity, confirming patency. And then a semen analysis would be important to ensure that there is adequate sperm, that they're likely to be able to meet the egg that's ovulated at the level of the fallopian tube and then the embryo implant in the uterus. So this is how I tend to categorize my testing for patients. So to go through it as a kind of a checklist in a bit more detail, in terms of ovarian testing, I do cycle day 2 to 4 FSH, LH, and estradiol. It's important that we can't interpret FSH if you have an elevated estradiol or if on the oral contraceptive pill. And the reason for that is because what we're looking is for premature elevation of FSH, as we talked about, which is associated with diminished ovarian reserve. But as we know, low to moderate levels of estrogen can be suppressive on FSH. So if you have an early rise in estrogen, that could actually suppress the FSH and not make it interpretable. It's almost like a false negative. So we have to make sure that the estradiol is at least less than 80 to be able to make sure that we can really interpret the FSH results correctly. Then an anti-Müllerian hormone, antral follicle count on ultrasound, and then that prenatal evaluation we discussed. In terms of cavity assessment, we talked about an HSG. We certainly can consider a hypoxia, but for someone who I suspect they might have a tubal disease, such as a history of PID or multiple pelvic surgeries or potentially a concern for endometriosis, I do tend to favor an HSG because it is more sensitive for tubal disease. I find hydrosalpinx or distal tubal blockage sometimes can be missed on a hypoxia. For male testing, we order an ID screen, a carrier screen, the minimum is cystic fibrosis or spinal muscular atrophy, but we certainly offer wider panels, and then a semen analysis. Now, this checklist is really only if a patient has irregular menstrual cycles. So I only order these tests if there are irregular menstrual cycles or concerns on history. So at that point, if someone's cycling, let's say every 3 to 4 months, I'm not going to wait till their next menstrual period. I'll order a random FSH, LH, estradiol, and P4, and essentially using these values, you can tell where the patient is in the menstrual cycle. Oftentimes, if their cycles are irregular, then they're suppressed. They're right at the beginning, and you can interpret these results. The way you can tell if they're at the beginning is if the LH is on the lower side, so no sign of an LH surge. If the estradiol is less than 80, and if the progesterone is less than 1.2, it suggests they are not luteal and therefore at the beginning of the cycle, and you can interpret the FSH in terms of ovarian reserve. We order prolactin again if there's irregular cycles or concerns for pituitary adenoma, such as galactorrhea or visual field deficits. A total and free testosterone, its levels over 200 nanograms per deciliter that might be indicative of a virilizing tumor. Often in PCOS, levels will be borderline elevated, but they do not get this high. If they do, then that's a sign that we need to do further evaluation for a possible virilizing tumor. Similarly for DHEAS, it's often borderline elevated in PCOS, but the levels are over 700 to 800 nanograms per deciliter. Again, we have to investigate for a possible virilizing tumor. We order 17-OHP. There is hirsutism to rule out congenital adrenal hyperplasia. I think this is sometimes missed and is pertinent because it does have genetic implications for offspring. If there is a suspicion of PCOS, I do order hemoglobin A1C or 2-RGTT. And then if there are stigmata of Cushing's, then it's reasonable to evaluate for that. So let's get back to ovarian reserve testing. Why do we do it? Well, the goal is to add prognostic information for counseling and a planning process. So it's very important when we see patients to have a grasp of that. Remember, it assesses only the quality, not quantity of the remaining oocyte pool. It should not be the sole criteria used to deny patients access to ART or other treatments. And it doesn't necessarily equate with an inability to conceive on their own or even through ART. So as long as someone's having regular menstrual cycles and releasing an egg every month, the chance of conception is there even if their pool is low. It shouldn't be used as a fertility test for women who are not infertile or have untested fertility. And that's important. I don't believe that ovarian reserve testing should be used to promote planned ovarian oocyte cryopreservation. This decision really should be based on a woman's reproductive plans and age. Once they're interested, certainly there's a role because it factors in terms of medication dose and anticipated response. But really, decisions on egg freezing should be based on reproductive plans and age. And, this kind of emphasizes the point that it's important to speak with patients about reproductive plans at all stages of reproductive life. So the ovarian reserve, which is antral follicle count, AMH, and day 2 to 4 FSH. Now, it's not a predictive of unassisted conception. We discussed that. As long as they're releasing an egg every month, the chance is there. And it's unclear how tightly associated it is with a chance of a live birth after ART. It does suggest that someone with a lower reserve may need multiple cycles, but in terms of cumulative pregnancy rates, it's unclear if there's a clear effect. Age is certainly more of a driver in that regard. But it does predict response to ovarian stimulation. We can, counsel the patient on how many eggs we anticipate and what the potential is from those eggs. It does predict the risk of ovarian hyperstimulation syndrome, so we have to tailor our ovarian stimulation protocol carefully. And there are evolving diagnostic criteria for PCOS that are not published yet, but they're looking at incorporating an elevated AMH in that diagnosis. And there's more and more studies looking at AMH in terms of being able to predict age of menopause. It's not so clear cut at this point. You cannot predict age of menopause based on a single AMH, but certainly if someone has a more diminished ovarian reserve, that does suggest a more narrowed reproductive window and a potentially earlier age of menopause. In terms of semen analysis, most labs, including our own, continue to use the WHO 2010, which requires a volume of at least 1.5 milliliters, a concentration of at least 15 per ml, motility at least 40%, and then morphology at least 4% using strict Kruger criteria. There hasn't been much change over the last decade in that regard. Now, these are tests that the SRM do not recommend organizing routinely. So laparoscopy for unexplained infertility. Advanced sperm function testing is usually reserved for individuals with recurring implantation failure or other concerns. Postcoital testing is quite antiquated. Thrombophilia testing, immunologic testing, karyotype in the absence of, an RPL history, endometrial biopsy, prolactin in the absence of irregular menstrual cycles, and then progesterone in the absence of irregular menstrual cycles. Again, in that case, let the history guide you if their cycles are regular. So briefly, in the last couple of minutes, I just want to go through some basics of infertility management. Certainly, if some individuals have interest in this field, it's not unreasonable to kind of start these initial steps, but we're also always happy to take these patients on. So in terms of counseling, the fertile window is actually a 6-day interval ending on the day of ovulation. So this is looking at a cohort of women and the chance of pregnancy based on a single act of intercourse, based on the days relative to ovulation. So you can see that the highest chance of live birth from an act of intercourse is actually 2 days prior to ovulation, ovulation being day 0. And that's because sperm live in a female reproductive tract for approximately 5 to 7 days, whereas an egg just lives for 24 hours. So it's very important to have sperm available in the reproductive tract even prior to ovulation. And the important thing to note as well is that these ovulation kits that we'll speak about, they detect LH surges, which occurs 24 to 36 hours prior to ovulation. So in fact, it's a little past even this peak fertile window. So definitely very important to encourage intercourse even before positive OPK, but definitely on the day of the ovulation predictor kit. After that, the chances really do go down on that month. So in terms of detecting ovulation, there's many different methods that patients tend to use. One is a calendar method. Sometimes there's apps that help support this. The issue really is that this is just based on the length of the menstrual cycle prior to the current cycle. So let's say someone has cycles varying from 25 to 35 days. If the last menstrual cycle is 25, then it's going to predict ovulation for next cycle based on that 25-day cycle interval. But their next interval is 35, it will no longer be accurate. So it doesn't account for cycle variability. In terms of cervical mucus monitoring, a lot of patients find it difficult for this to be reliable, but essentially the volume and the slipperiness increases 2 to 3 days prior to ovulation. And then the issue with basal body temperature monitoring, it's nice in that there's more objective data there, but the rise actually occurs after ovulation. And we just saw the fertile window is really peaked before that. So it's helpful to kind of confirm that there's ovulation. But again, it's not that helpful to time intercourse for that particular cycle. In terms of urine ovulation kits, I think that there's a lot of emphasis on a patient level for detecting ovulation. Again, as long as you're having intercourse, a couple of times, we usually recommend optimal is every 2 days during an ovulatory period. So that means for a 28-day cycle, usually from day 10 to 18, then you're targeting ovulation. It's not wrong to want more data, but oftentimes that's not the issue. If a couple has been trying for about a year, usually it's not timing unless they live, in different countries. That's the issue. So it really should not replace a comprehensive fertility evaluation. What it does is detects the amount of urinary LH. You start on day 10 and continue until you detect a positive or roughly until cycle day 20. If you're still negative, then certainly speaking to a fertility specialist makes sense. It's important to ensure that the test is done at the same time every day, preferably first thing in the morning when urine is concentrated. So you don't want someone to chug a few liters of water prior to doing the test because you can get a false negative from diluted urine. Again, if you can't test consistently at the same time every day, you're not detecting a surge and your cycles are regular, it's not unreasonable for at least 1 month to try considering testing every 12 hours to make sure you're just not missing it in terms of timing. Beware of an early or constant positive. We get this all the time where patients say, I started testing on day 8 and it's positive the entire time. Well, that might be detecting high baselines levels of LH, which is very common in women with PCOS. So it's not incredibly helpful to use OPKs in the PCOS population unless they're on medication. In terms of specific brand, we don't have one that we prefer, but I would say my patients do report that having a clear sign, so either a positive or a happy face, is a little bit more easy to interpret as opposed to a subtle color change. But personal preference is fine here. So just in terms of the basics of ovulation induction, this is a method of inducing ovulation in the anovulatory woman. It should be considered with lifestyle optimization. So if someone has PCOS, ensuring that we're working on optimizing their BMI certainly makes sense because a decrease of body weight by 5 to 10% can restore normal menstrual cycles and it also make them more responsive to ovulation induction agents. Generally, this is done with either letrozole or Clomid. There are studies supporting letrozole as the first line in the PCOS population. Now, this is important. There's no evidence of benefit from ovulation induction agents alone in ovulatory women. If women have regular menstrual cycles, adding letrozole or Clomid, this has been studied many, many times, does not increase the chance of them becoming pregnant. It can actually delay further testing and treatment. So that's an important point. Also, it does not work in cases of hypergonadotropic hypogonadism, meaning premature menopause, or hypogonadotropic hypogonadism, meaning either a central cause, a CNS pathology, or severe exercise and dietary restriction induced hypogonadism. Generally, they don't respond to these agents. The way it works is essentially letrozole blocks estrogen production, and estrogen, as we said, at moderate levels has a negative feedback mechanism. So when this negative feedback is removed, then the pituitary starts secreting gonadotropins, particularly FSH, follicle stimulating hormone, and that leads to follicular development. So I'll speak briefly about letrozole specifically, but generally you start with 2.5 milligrams for 5 days from cycle day 3 to 7 or cycle day 5 to 9, cycle day 1 being the first day of full menstrual flow, not spotting. You can have patients monitor with ovulation kits, and then I tend to confirm, at least with the first cycle, whether or not they have a luteal progesterone on day 21, because it's a bit more objective. If there's no positive ovulation predictor kit and cycle day 24 progesterone is less than 3, then I would increase the dose next month by 2.5. The max dose is 7.5. Now, we previously classically would give them progestin prior to that to induce a withdrawal bleed. But unless their lining is extremely thick on ultrasound, there has been studies suggesting that inducing withdrawal bleed doesn't improve pregnancy rates. So you can actually step up and increase the letrozole dose by 2.5 if the cycle day 21 progesterone shows no ovulation. At that point, you can just add and increase it to about 5 milligrams. It's called a step-up protocol. In times of side effects, fatigue, headaches, and vasomotor symptoms are common, usually not overly bothersome. It's just related to the lower estrogen levels from the mechanism of action of letrozole. And the risks, so the baseline risk of multiples in the population is approximately 1 to 2%. With letrozole and Clomid, it increases it to approximately 3 to 7%. So still, the overwhelming amount of pregnancies are singletons, but it does increase that risk. So this is a little chart of what it would look like. So day 1, first day of full flow, and you start the letrozole usually day 3 to 7 or day 5 to 9. You would start testing for ovulation around day 10. If their cycles are shorter, you can start a little earlier. And then if they have a 28-day cycle, generally they would receive a positive ovulation sign on day 14. And we would encourage intercourse that day, even the day prior, if they're able to kind of time things. And then for the next couple of days, just to ensure that they've met this fertile ovulatory window. We then do recommend, at least for the first cycle, a day 21 progesterone to confirm ovulation. In terms of other modalities that we use for patients who are not responsive to ovulation induction, who have other reasons of infertility, one of our first lines is a medicated intrauterine insemination or IUI cycle. Generally, we give Clomid or letrozole to patient, and then they are brought in following a positive ovulation kit, or sometimes we can arrange monitoring. The sperm is processed to pull out concentrated motile sperm and is delivered directly into the uterus via an insemination catheter. This allows it to bypass the vagina and the cervix and brings the motile sperm in closer proximity to the egg. Generally, most patients find this procedure not uncomfortable. They primarily feel just a speculum exam. The catheter is very flexible and quite small, so most patients find it very, very tolerable. It's often used for unexplained infertility, mild male factor, cervical stenosis, or then women who would like to be single parents by choice or same-sex female couples. In terms of the success, IUI success is generally within the first 3 cycles. So if a couple has been trying to conceive for a year and is not successful, their chance per month goes down to less than 5% per month. So we use that as a reference. With IUI, it nearly doubles or triples it, so it goes to about 10 to 15% per month, but you can see that the success rate does plateau after 3 cycles, meaning that if you're not pregnant after 3 cycles, it's likely that this medicated IUI protocol is just not addressing the cause for infertility, and we'd recommend moving on. Then finally, IVF, that is when we take advantage of the fact that women make a big cohort of eggs every month only to ovulate one and have the rest undergo atresia. They don't undergo atresia because they're abnormal. They just undergo atresia because there's just enough FSH to really push forward one dominant follicle. So we give subcutaneous FSH injections under the skin, usually for about 8 to 12 days. Eventually, we add something to prevent ovulation as well. And then we bring the patients in for monitoring roughly 3 to 4 times during this period of injections. And we're doing blood work to ensure that they're making estrogen because healthy eggs make estrogen. And then we're measuring the size of these follicles, which are essentially sacs of fluid with eggs in them. And fluid, as we know, shows up as black on ultrasound. So there's likely to be mature eggs when the follicles reach about 18 to 22 millimeters. During this time, patients could continue doing their regular activities. Monitoring sessions are quite early, so 6:30 in the morning is an earlier one, so most patients can continue on and do kind of their work-related activities for the day. The only restriction is no high-impact activity. Because the ovaries are enlarged, there's a risk of torsion, so we ask patients not to do any kind of running, jumping, dancing during this period. Certainly some swimming or biking would be fine. So then once the follicles reach the appropriate size, we trigger ovulation with one final injection, and then 36 hours later, we do the egg retrieval. This is the one step where patients need to be off work for 24 hours because it's under anesthetic. They're breathing on their own, but they do not remember or feel a thing. I actually had a patient wake up the other day and ask me when we're going to do the procedure, and this was after when she's post-operative. So truly do not remember anything. But essentially, we put an ultrasound, a transvaginal ultrasound probe with a 17 or 18 gauge needle. We drain all the sacs of fluid. We give that fluid to lab. They sift through it, and they have an egg count prior to leaving that day. There is a small risk of infection and bleeding, but it is ultrasound guided, so the risk is quite low, less than 1%. We then inseminate the eggs. We tend to favor conventional or classical insemination, meaning we let the sperm find the egg if the sperm parameters are normal and there's no history of failed fertilization, because there's thought to be a selective mechanism here that may optimize embryo development. But there is severe male factor, then actually we only need one sperm per egg we have. So even men with very, very low sperm counts or just testicular sperm can create embryos using this technology. We grow the embryos and then we transfer them generally one at a time into the uterus. This is similar to an IUI in that patients are awake. It's a short appointment, generally mostly feel just a full bladder and then the speculum exam. We do have a technology I'm sure everyone's aware of, PGTA, pre-implantation genetic screening for aneuploidy. And essentially, this is what embryos look like when they're blastocysts on day 5, 6, or 7 after fertilization. There's a cluster of cells, the inner cell mass, that becomes a fetus. And then there's the cells on the outside, the tropectoderm, that becomes a placenta. Our lab has the ability to take about 5 cells that will become the placenta and send it for analysis. It is a screening modality, so it's not 100%. There's approximately 5% false negatives and false positives, but it tells us if the embryo is likely to carry the right chromosomal content. Is it 46XX or 46XY? And that's important because we have a normal embryo, a euploid embryo, then the chance of implantation is quite high. It's 50 to 60%, and that's irrespective of age. The 41-year-old is able to get a euploid embryo. That's the chance of pregnancy and live birth. And it does reduce the chance of miscarriage as well, because as we know, most miscarriages are related to embryonic aneuploidy. Now, in terms of success rates for ART using autologous eggs, again, we have many different technologies to try to overcome many aspects of infertility, but age certainly still matters. For someone that's in their mid-30s, the chance of success per cycle is about 40 to 50%, but at 43 years old, it gets to less than 5%. And generally, when we start seeing, live birth rates of less than 5%, at that point, or even earlier, we start bringing up the the discussion of donor egg, because as we presented at the beginning of the talk, donor egg is associated with a high chance of live birth, even when women are in their late 40s. So that's the end of my talk for today. I'm looking forward to hearing from you and any questions that you have. I'm always accessible by email. I'm checking it all the time, so feel free to send over any questions or anything I can assist with.